Good evening. I'm Patricia Stark, the host for this evening's broadcast. I would like to welcome you to this live national program entitled A Case-Based Introduction to TEVIMBRA, tislelizumab, a first-line treatment for adults with unresectable or metastatic ESCC, whose tumors express PD-L1 greater than or equal to 1 in combination with platinum-based chemotherapy, and unresectable or metastatic HER2 negative gastric or gastroesophageal junction adenocarcinoma, whose tumors express PD-L1 greater than or equal to 1 in combination with platinum and fluoropyrimidine-based chemotherapy. This evening's broadcast is sponsored by B1 Medicines. Our expert panel has been selected by B1, and the panelists are being compensated for their participation. To begin, I would like to introduce you to our faculty. Dr. Mahipal is a professor of hematology and oncology at University Hospital's Seidman Cancer Center and member of the Developmental Therapeutics Program at Case Comprehensive Cancer Center. Dr. Iqbal is an associate professor and section chief of gastrointestinal oncology at the Keck School of Medicine of University of Southern California, Norris Comprehensive Cancer Center. She also serves as medical director of both ambulatory infusion and inpatient services for Norris Cancer Hospital. Tonight, our faculty will be focusing on TEVIMBRA and its use in ESCC, as well as gastric cancer and gastroesophageal junction cancer, while providing their thoughts and relevant data applicable to your practice. At the conclusion of the program, the faculty will be answering questions submitted by you, our audience. Now, there are a few easy ways for you to submit questions to our panelists. You can text your questions to 912-378-1244. That number again, 912-378-1244. Or you can email your questions to ask@inceptioncompany.com. That's ask@inceptioncompany.com. And please provide your name and email address along with your question, and we'll follow up with you directly if we happen to run out of Q&A time. Throughout the presentation, we'll display that text number and the email address across the bottom of the screen. For those of you listening at home, you can also submit a question by simply clicking on the Ask a Question box on your screen, typing in your question into the text box, and clicking the Submit button. For those of you at local meeting sites, your host will describe the process of submitting questions. Our panel will answer as many questions as time permits right up until the end of the program, and then I'll be back to wrap up the broadcast. If we are unable to answer your questions before the end of the program, we will follow up with responses offline. Here are the presentation objectives. Tonight, through a case-based discussion, we will provide a brief introduction into advanced metastatic ESCC and GEJC and the unmet needs in treating these two cancers. We'll review the efficacy and safety results of key TEVIMBRA trials in ESCC and GC-GEJC. And then we'll discuss the dosing and administration of TEVIMBRA, as well as outline the MyB1 support program and the benefits it offers patients. So to start us off, here is Dr. Mahipal. Doctor.
Thank you. My pleasure to be here, and thanks everyone to listen to this program. So today we'll talk about TEVIMBRA, or tislelizumab. It's a unique PD-1 inhibitor which is designed for robust T-cell activation. And we'll talk about two indications. One is the esophageal squamous cell cancer, and other is gastric or gastroesophageal junction cancer. So when we talk about esophageal cancer, it's indicated or FDA approved for patients in combination with chemotherapy as a first-line treatment for advanced or metastatic esophageal squamous cell cancer whose tumor express PD-L1 1 or higher. Then it is also approved as a second-line agent or later as a single agent for patients who have progressed on prior chemotherapy. Then we have an indication for gastric or GE junction cancer, where it's again approved as a first-line treatment for advanced patients in combination with chemotherapy, so platinum plus fluoropyrimidine, again in patients who are PD-L1 positive or 1% or higher. We'll talk about the side effects of the immune-mediated adverse reactions, but I think overarching theme is immune-mediated adverse reactions can happen. It can it can present with any organ of the body. So we just have to be careful. Early diagnosis and management is the key. And in some cases, it can be very severe and fatal. And typically, we give immunosuppression or corticosteroids to help calm down the inflammatory system and take care of the immune-mediated adverse reactions. And in some cases, we have to obviously discontinue or stop the treatment depending on the side effects or depending on the AE and the grade of AEs. Now, just talking about a little bit about epidemiology. So in 2025, or like about every year, we see about 7,000 patients with esophageal squamous cell carcinoma which are diagnosed in the United States. However, if you look at the world over, it's a huge problem. More than 500,000 patients are diagnosed. And now, again, switching to gastric cancer, the incidence is much, much higher. It's about 30,000 patients are diagnosed in the United States with gastric cancer. And of those, about 6,600 patients have gastroesophageal junction cancer. I mean, again, many times we actually treat these patients, gastric and GEJ junction cancer, as a kind of a same cancer in a way. If you look at the prognosis is extremely poor. The 5-year survival for gastric cancer is 7% and esophageal cancer is 5%. So we're dealing with a disease where there's extremely poor survival, and we need new therapies to advance the treatment management for these patients and improve their outcomes. So again, we're talking about, again, the two cancers. First esophageal squamous cell cancer. If you look at the first-line treatment, the current landscape, the median survival is less than 14 months. And these are the patients who present with very debilitating symptoms like fatigue, nausea, vomiting, weight loss, dysphagia. And again, talking about gastric or GE junction cancers, it's kind of the same issue. The median survival remains less than 14 months, so really poor. And I think interesting fact is about half the patient with gastric cancer present with peritoneal metastases. And what we know about that is that patients who have peritoneal metastases have very, very poor prognosis. So their outcome is even worse than what we are seeing for other cancer, for other patients with gastric cancer who do not have peritoneal metastases. So now talking about, we said before that TEVIMBRA is a unique PD-1 inhibitor. So how is it different? So it is specifically designed, the Fc gamma receptor, so that it is not easily bind to the macrophages. As a result, this PD-1 in combination with T cells, they remain in the tumor microenvironment where they can help with the tumor inhibition. So this is, again, a uniquely designed PD-1 inhibitor which helps in robust T cell activation much more than other ones in the past. So here's some preclinical data where they're looking at PD-L1 binding with different drugs, including nivolumab, pembrolizumab, and TEVIMBRA. And as you can see with TEVIMBRA, the IL-2 secretion is actually at the same concentration level, is more than 99% compared to only 80% binding with nivolumab and pembrolizumab. Again, just to be clear-cut, I mean, this is a preclinical data, so it may or may not translate to the clinical data, but we'll discuss about the clinical data as well. But preclinically, again, what we are seeing is a unique PD-1 inhibitor. It does cause higher T cell activation and seems to be better in terms of the PD-L1 binding compared to the existing agents.
And Dr. Iqbal, what are your thoughts on the unique design of TEVIMBRA?
Yeah, so I think it's reassuring that we're seeing inhibition of PD-1 and PD-L1. I think what's interesting is that in comparison to nivolumab and pembrolizumab, we're seeing stronger binding, stronger inhibition. In addition, I think the thoughts are that this mechanism may be relevant in particular clinical scenarios in which the macrophage clearance may be an issue, for example, in peritoneal metastases. But in general, I think the preclinical data are reassuring. I think it's yet to be determined what the clinical implications of all of this are going to be.
And how might these characteristics be important as a treatment for upper GI cancer?
So we know that PD-1 inhibitors are active in this disease, right? So I think the question is now, are we going to try another PD-1 inhibitor, or is there a different mechanism of action and we can still target the PD-1 pathway but have a drug which actually works better than the existing drugs?
Great, thank you. So please start our discussion of TEVIMBRA in ESCC with our first case, if you will.
Okay, great. So we're going to talk about esophageal squamous cell carcinoma. We're looking at Michael, who is a 61-year-old male who presents with fatigue, progressive dysphagia, weight loss. He was diagnosed with COPD about 7 years ago. He uses some bronchodilators for such. He has a history of acid reflux disease, and he uses PPIs to manage that. His social history is relevant for smoking, and he drinks about 2 to 3 beers per day. He quit smoking, though, when he was diagnosed with COPD about 7 years ago. In terms of his family history, relevant for a father with lung cancer, we see the concomitant medications here, and the relevant clinical exam findings are that his ECOG performance status is 1, and we see evidence of weight loss. As we move on to the laboratory data, he's slightly anemic with a hemoglobin of 11.2. LFTs are elevated. He has an EGD for the progressive dysphagia, and he's found to have a large mid-esophageal mass, which is partially obstructing. The biopsy is consistent with squamous cell carcinoma, and a staging PET-CT reveals metastases to the liver and the mediastinum. An ultrasound of the liver reveals hepatic steatosis, a reflection probably of his alcohol use. Now, relevant biomarker evaluation reveals proficient mismatch repair genes, MSI stable, and a PD-L1 expression of 15%.
So is this patient representative of the patients with ESCC that you see in your practice?
Certainly. Usually we're seeing patients who have significant comorbidities. They tend to be more ill. They tend to be smokers and drinkers. So I think this is absolutely a patient who's reflective of an esophageal squam presentation.
And what aspects of this case are important when considering treatment for this patient?
Yeah, I would say, some of the same things that Dr. Iqbal mentioned, like what are the comorbidities? Like we know this patient has COPD, has a history of drinking and smoking. What is the performance status? So it seems like it's a good performance status, so that's reassuring. The labs are kind of within the normal with some small exceptions like LFTs and hemoglobin, but not too far off from being normal. And I think other important thing is the biomarkers, right? So we look at the MSI MMR, is MMR proficient, and PD-L1 positive is more than, actually 10% is 15%. So again, PD-L1 positive typically we defined as 1% or higher. Here we definitely see a very PD-L1 positive tumor.
Okay, we'll revisit the case later in the presentation. So, Dr. Iqbal, how has the NCCN updated its guidelines to reflect the new data and ESCC indication for TEVIMBRA?
Sure. So TEVIMBRA has a Category 1 recommendation for patients with esophageal squamous cell carcinoma in the frontline setting, unresectable, locally advanced, or metastatic disease to be given in combination with chemotherapy for patients with PD-L1 expression of 1% or greater. And this is in line with the new ODAC recommendations, which is relevant to all of the current PD-1 inhibitors. Tislelizumab also has a Category 1 recommendation for subsequent lines of therapy as well. So that's the newest change to the NCCN guidelines.
Okay, great. Thank you, Doctor. Now, if you could take us through the discussion of Rationale 306.
Sure. So Rationale 306 is a randomized phase 3 study, double-blinded, placebo-controlled, which randomized patients 1-to-1 to TEVIMBRA in a Q3-week regimen with physician's choice of platinum-based chemotherapy. So this included fluoropyrimidines and platinums versus chemotherapy alone, and patients were treated until disease progression. So the study initially accrued all comers, but based on the ODAC guidelines and the new recommendations that came from that, which is for treatment with IO for patients with a PD-L1 score of 1% or greater, I'm going to present the key efficacy endpoints for that patient population. So the primary endpoints were survival with the usual secondary endpoints, which include response, progression-free survival, as well as safety. Key eligibility criteria in this study were untreated patients, reasonable performance status, reasonable organ function, and these patients had measurable or evaluable disease. And patients were stratified based on the region, Asia versus non-Asia, as well as the backbone of chemotherapy regimen and the other factors that are listed here. If we look at the patients who participated in the study, the arms were actually well matched, mostly males, ECOG performance status largely of 1 in this patient population, and the majority of these patients were smokers. although 75% of the patients were Asian, because this was a global study, we did have approximately 25% of patients who were white, and the majority of patients had metastatic disease. I think what's important to note here is that the PD-L1 score was evaluated by way of TAP, but as will be discussed, TAP has been shown to be concordant with the CPS score. So any evaluation of PD-L1, based on any FDA-approved kit or per your institutional guidelines, is an appropriate assessment of PD-L1 status.
So what are your thoughts regarding the patients in this study?
Yeah, I think this is pretty reflective of the global population. This disease occurs largely in Asians, but I think what's important here is that there were approximately 25% of patients who were white who also participated in the study, and it is reflective of our population as well here in the West.
Okay, great. Doctor, did you want to add something?
No, I would just echo those comments, right? I mean, a couple of other things. I mean, about 40% of the patients received some definitive therapy prior to starting on this. This is, again, a first-line systemic therapy trial, but as Dr. Iqbal mentioned, that this is very representative of the global population as well as the Western population and the patients who were accrued in this trial.
So then would you say these patients are representative of the patient population that you would expect to treat in your practice?
Sure.
Absolutely.
Okay, great. All right. Can you also address the chemotherapy backbones that are used in the study?
Yeah, so what was interesting about this study was that it was any platinum-based chemotherapy because it was a global trial. There was taxane plus platinum, fluoropyrimidine plus platinum. And so I think the uniqueness of this study is that it gives us a broad overview of the chemotherapeutic options that we can use in combination with immunotherapy, specifically tislelizumab, and we'll see the efficacy data that we'll see that there was efficacy and activity with these combinations.
All right, great. And what value does flexibility in chemotherapy have for clinicians treating patients with these cancers?
Go ahead.
So patients may have comorbidities that prevent us from using particular agents. They may not want to have a pump. Also, I think what the study did was it was reflective of regimens that are also used in Asia more commonly than they are in the United States. And in our practices, we usually use fluoropyrimidine, oxaliplatin-based regimens.
All right, terrific. All right, Dr. Mahipal, please continue with the study.
All right. Thank you. So we'll going to focus on the PD-L1 expression. It was just mentioned that we can measure PD-L1 expression in different ways. And a couple of more common ways is tumor area positivity or CPS or combined positive score. So what is TAP score? What they're looking at is a visual estimation of PD-L1 positive tumor cells or immune cells. So, they look at the whole slide, number of cells, and they just look what percentage are positive. And then CPS score, you actually individually count the PD-L1 positive tumor cells, lymphocytes, or macrophages. But the important thing is, whether you use TAP score or CPS score, there's a very, very high degree of concordance, actually 97% concordance for patients who are like 1% or higher. So it actually doesn't matter which scoring system you use. So whatever the institution, whether you use TAP or CPS, you get the similar results. So now talking about survival, right? So what we see is, as compared to FOLFOX plus placebo or FOLFOX alone, or chemotherapy alone, I should say, whether you use FOLFOX or carbotax or whatever regimen they use, compared to chemotherapy plus TEVIMBRA, there was a huge improvement in the median survival. The median survival improved from 9.6 months to 16.8 months. And this is somewhat unprecedented, as we have never seen this high degree of survival in a randomized phase 3 trial. And I think more importantly, then we talk about some landmark survival. So we have always been talking about median survival for a long time, but now we are going to a stage where I think as we're improving the outcomes, looking at 1 year survival, 2 year, 3 years, because a lot of our patients ask for not just my average survival, but they ask what are my chances to make it to 1 year, 2 years, or some landmark in their life that they might have, like to make to a wedding or to make to a grandkid that might be coming up or so on. So here, what we look at the 1 year survival is a difference 42% versus 65%. At 2 years, again, improvement from 23 to 37%. At 3 years, for 14 to 21%. And what you see is a separation of curves remains. So many times when we do these trials, we look at the curves separate, there's a gap between in the middle, and then at the end, again, they meet each other. So here, at least so far, with the follow-up that we have, we are seeing separation of the curves, and then hopefully it would translate into a higher number of long-term survivors. But we'll continue to see the follow-up data. But this is very, very reassuring. And first time we are seeing 3 year survival differences.
Mm-hmm. And what are your thoughts on the overall survival data?
So just talking about, so we talk about overall survival improvement we have seen with other immunotherapy. I think the biggest thing is what we are seeing is really a huge difference. And as I mentioned again, we are seeing the 3-year difference that we have not seen before. So this is somewhat like actually not only reassuring, but something surprising and very encouraging that we are improving the outcome for these patients where traditionally the outcomes have been extremely poor.
Okay. And how is the survival curve different than what you've seen in the past with immunotherapy agents for first-line ESCC?
So, I mean, other immunotherapy agents also have demonstrated a survival benefit. I think there's clearly a class effect with PD-1 inhibition in esophageal squamous cell. I think as we compare these agents, which we're not to do across studies, this is the longest survival that we've seen of a PD-1 inhibitor with chemotherapy. And in addition, I would say that this is a study that's actually offered us variable chemotherapy regimens with tislelizumab, with a PD-1 inhibitor, and reassures us that we can use a drug with a platinum regimen of choice, giving us options for our patient population.
All right, terrific. And Dr. Mehapal, please take us through the rest of the efficacy data.
Absolutely. And I would again just echo one comment, like, you know, we don't want to do cross-trial comparisons, so just to keep that in mind, so we should look at every trial individually. So looking at the subgroup analysis, so we do the subgroup to again see if there are specific subgroups that do not benefit or they benefit a lot with these treatments. And if you look at across, right, you know, whether with race, we talk about like it's a predominantly Asian study, so Asian versus white, whether it was done in Asia or outside Asia, all the dots are on the left side of this hazard ratio 1, which is suggesting that all the subgroups tend to benefit, and there's no particular subgroup that we see that do not benefit from addition of PD-1 or TEVIMBRA in this case to chemotherapy. Then again, looking at other outcomes, so survival was obviously the main primary outcome of the study. We're also looking at progression-free survival as well as response rate. So median progression-free survival improved from 5.5 to 7.2 months. We also look at the response rates, it improved from 36% to 58%. So what we are seeing is not just outcome in survival, but as well as the secondary endpoints like response rate and progression-free survival as well.
And for both of you, what are your thoughts on the additional efficacy data?
So just talking about the response rate, I mean, so some of these patients, when they present with their symptoms from their disease, like dysphagia. And for many of those patients, the response are really important because if they have responses, they could have significant improvement in their symptoms. And secondly, I think what we are seeing is a consistency. We're looking at, okay, the addition of TEVIMBRA is improving the response rate, they're improving the progression-free survival, and that's what's translating into the survival benefit.
Dr. Iqbal?
Yeah, I agree with that. Yeah.
All right, terrific. All right, well, thank you. So, Dr. Iqbal, if you could take us now through the safety data, that would be great.
Sure. So in terms of adverse events on Rationale 306, there really were no new safety indications. So I think it's reassuring to know that the adverse events that were noted were largely due to chemotherapy, and in addition, the class effect of PD-1 inhibitors. In terms of discontinuation of drug, this occurred in a small number of patients with immune-related toxicity, largely due to pneumonitis and, I believe, rash in this population.
And what do you take away from the review of the safety data then?
Yeah, like I said, I think it's reassuring. These are class effects that we see with these drugs. I think we're used to managing the immune-related toxicities now, given our experience with immunotherapy.
All right. How does this compare with what you'd expect from other currently approved IL therapies?
I think it's not surprising. I mean, what we see, again, we see some addition of immune-mediated AEs with addition of any of the PD-1 blocker. And we are seeing similar thing with addition of TEVIMBRA to chemotherapy. The good thing is, again, as Dr. Iqbal mentioned, that we are not seeing anything new safety signal that we'll be highly concerned about. So.
All right, terrific. Well, now let's revisit the case. How would you manage Michael's treatment at this point? What considerations would guide your treatment plan?
Good.
He's a gentleman with metastatic disease. He has a reasonable performance status, reasonable organ function, and he's PD-L1 positive at 15%. So clearly he's a candidate for chemotherapy, in my opinion. And so I would offer him chemotherapy plus immunotherapy, or tislelizumab, I think, is a excellent option for him. In terms of other factors, I think I just want to mention that usually in the United States, what we're doing is using FOLFOX plus chemotherapy. So that's our kind of our go-to combination of choice.
Okay. And if you treated Michael with TEVIMBRA regimen, what results might you anticipate?
I think that we just discussed trial data. We'll talk about the increased response rates, progression-free survival, and leading to overall survival benefit. And I think we expect to achieve somewhat similar results. I mean, this patient is very, very representative of the trial population with good performance status. But obviously, individual outcomes for individual patients is very, very hard to predict. But this is just an expectation in general for our patients.
Mm-hmm. Understood. For a patient like Michael who has multiple comorbidities and is taking multiple medications, what value would a patient support program provide, do you think?
Yeah, so I'll take that. Yeah. So yeah, that's actually an interesting question. So a lot of our patients, especially who are older, they tend to have multiple comorbidities. They are on multiple medications, and there are a lot of interactions that can happen. So our patient support program could help with sort out of these medications. We have dedicated pharmacists who actually helps as well, looking at if there's no interaction with the cancer treatment as well as the medications within themselves.
Okay. Great, thank you. All right, Dr. Iqbal, please take us through the next set of ISI.
Sure. So the immune-mediated toxicities or adverse events, like I said earlier, are similar to what we've seen with other immunotherapy regimens. These can occur at any time during the treatment with TEVIMBRA. And actually can occur also after the drug has been discontinued. They're managed by stopping drug if that's indicated, and then intervening if necessary if patients have grade 3-4 reactions with steroids, or there's escalation from steroids as well if needed. In terms of the specific immune-related toxicity, we have pneumonitis that occurred in 4.9% of patients, and actually generally, the immune-related toxicities were in less than 5% of patients. Others listed include colitis, hepatitis, but what we see most commonly are the endocrinopathies, and actually hypothyroidism is the most common at a little over 12%. Hypothyroidism really hasn't led to discontinuation of drug in the reporting thus far with TEVIMBRA.
All right, thank you, Dr. Iqbal. And Dr. Mahipal, could you please start our discussion of TEVIMBRA for GC, GE, JC at this time?
Absolutely. So now we're kind of switching gears from esophageal cancer to now gastroesophageal or gastric cancer. So we'll present this case. So this is a 63-year-old female who presented with 4 to 6 weeks of, again, kind of a chest pressure radiating to the back, some abdominal discomfort, but no real dysphagia. Patient did have a history of H. pylori, was treated in 2016, non-smoker, and occasionally drink wine, So otherwise very healthy patient, just has a hyperlipidemia and physical exam, like nothing abnormal. So when we look at the labs look good. Actually, apart from the hemoglobin, patient is anemic with 9.8. We talk about a little bit of hyperlipidemia. Patient underwent endoscopy, appropriately so. We showed actually a cancer about just 3 centimeters above the GE junction, and biopsies were obtained. And biopsy unfortunately showed moderately to poorly differentiated adenocarcinoma. So patient had further workup with imaging studies to rule out metastases, and was unfortunately found to have metastases with involvement of multiple liver lesions as well as peritoneal lesions. In addition, there were some lymph nodes involved as well. And as I said, the biopsy came out to be adenocarcinoma, so they did some biomarkers like HER2 testing, MSI testing, claudin, and PD-L1. And this is kind of a very important point. So now we don't want to treat these patients without doing these biomarker testing. So, when someone says diagnosed with adenocarcinoma, the treatment is not just some generic chemotherapy, but it's very, very directed based on what biomarker we say. So for this patient, the HER2 was negative, MMR proficient or MSI stable, Claudin 18.2 is negative as well, and then PD-L1 was 10%.
So is this patient representative of the patients with GC, GEJC that you see in your practice?
Yeah, I would say so. I mean, so this is, again, one of the typical patients, like some of the gastric cancer patients may or may not have some history of smoking or alcohol, but that could also be associated. It's not unusual. This patient did not have any comorbidities, so from that perspective, it's a very healthy patient. Many of the patients would present with dysphagia or difficulty swallowing. Here, this was a mild symptom, so the patients could have been diagnosed at early stage, but unfortunately, by the time the patient presented with symptoms, already had metastasized to the liver and peritoneum.
I would just also add that the pattern of metastases is actually quite consistent with what we see in metastatic gastric or GEJ cancer, where peritoneal metastases is associated with a very poor prognosis. These patients tend to be quite difficult to treat, and their outcome is usually worse than patients who do not have peritoneal disease.
Okay, so what biomarkers are most important to test for in GC, GEJC patients?
So there's a host of biomarkers that we assess now. HER2, mismatch repair deficiency basically should be assessed in all of our patients, especially esophagogastric patients, MSI testing, and then a PD-L1 evaluation to determine whether they're candidates for immunotherapy. And now we also have Claudin 18.2 with a monoclonal antibody that has been approved to target that receptor as well, or that protein as well.
And what is the turnaround time for receiving the results?
Well, that depends on the institution and what practices we use. So typically for immunohistochemistry testing, so a lot of these are just protein expressions. It's take about 3 to 5 days. But again, it depends on the institutional capabilities and whether you're doing the test in-house or you're sending it out. So if you send it to external vendor, there's a time involved in sending the tissue to the external vendor as well. So again, depending on the institutional practices, but typically 3 to 5 days. Dr. Iqbal, what's your thoughts?
I mean, to be honest, I think in clinical practice it can take longer. Sometimes it can take a couple of weeks even. So what we've been doing is actually off study. We start chemotherapy in a patient as we await the biomarker testing, and then pivot as we have the biomarker evaluation and can then add the relevant therapeutics at that time.
Yeah, I would just add one more point to this. I mean, this is something I think in GI world we are all struggling. Some of the other cancers, they do not treat the patient before they get the biomarkers, and for some reason we have continued this practice of just treating the patients. We have to change, and we have to do biomarker reflexively on these patients. As just Dr. Iqbal mentioned, if you don't do reflexively, by the time patient comes to see an oncologist, and then we are ordering the test, I mean, as the patient wants to start treatment, it becomes very difficult. So I think some of the other cancers like breast cancer, lung cancer, they're classic examples where they would not treat the patient, and they have established protocols. As soon as it's diagnosed, they get all these biomarkers. And we hope that somehow in GI oncology, we can reach that stage as well. So.
Okay. All right, very good. Thank you both. We'll return to this case later in the presentation. And Dr. Iqbal, how has the NCCN updated its guidelines to reflect the new data and first-line indication for TEVIMBRA for GC, GEJC?
Sure. So tislelizumab in combination with chemotherapy is now a Category 1 treatment option for the first-line treatment of patients with PD-L1 positive CPS score of 5 or greater, and then a Category 2A for PD-L1 of 1 or greater, again, in advanced disease. HER2 negative patients. So I just want to go back to the PD-L1 of 1 or greater is reflective of a class recommendation based on the ODAC guidelines. So just to create consistency among the biomarker evaluation and subsequent treatment, PD-L1 of 1 or greater is the recommendation that came out of ODAC last year. So we have Category 1 indication for an expression level of 5 or greater, and a Category 2A for an expression level of 1 or greater.
All right. And doctors, what are your thoughts on the efficacy results for TEVIMBRA with patients with advanced or metastatic GC, GEJC?
So we're going to talk about this, and Dr. Iqbal will
I'm going to go through the data right now.
Okay, great.
Okay, so Rationale 305, again, a global randomized double-blinded placebo-controlled phase 3 study, which randomized patients to TEVIMBRA plus fluoropyrimidine platinum versus chemotherapy alone. Again, patients were treated until progressive disease or toxicity. The key efficacy outcomes that I'm going to present are based on that 1% PD-L1 score. The overall survival was the primary outcome, and then the additional, again, the progression-free survival, response rate, and subsequent toxicity. Key eligibility criteria, these are patients that are gastric or GEJ adenocarcinoma, untreated with a good performance status, HER2 negative. And I want to point out the stratification factors. The stratification was not only by region, but also by site of metastases, specifically peritoneal disease for those patients with a PD-L1 of 1% or greater. And then the other stratification factors are listed. If we look at the arms of and the characteristics of the patients who participated in this study, again, they appear to be well matched and are reflective of the population. These are male patients, largely Asian, as this was a global study, but again, over 20% of these patients were white, good performance status, mostly 1. With metastatic disease, and 40% of patients actually had peritoneal metastases. Once again, I just want to mention that the PD-L1 score in this study was assessed by way of the TAP score, but as you heard earlier, TAP has good concordance with CPS, and so whatever your institutional guidelines are or what you're using for your FDA-approved evaluation is appropriate to assess for the PD-L1 status. If we look at the primary outcome measures, specifically overall survival, there was superiority for the patients who received tislelizumab or TEVIMBRA with chemotherapy versus chemotherapy alone at 15 months versus 12.8 months. And this was a hazard ratio of 0.76. And then if we also follow up with this overall sustained 3-year survival, we see that there's a separation in the survival curves, which is maintained, and at 3 years, 21% of patients are still alive versus 13% in the patients who were receiving chemotherapy alone. Again, an exploratory endpoint, but as Dr. Madpal discussed earlier, reflective of prolonged sustained impact of the drug. So if we look at the forest plot for these patients who benefited, you can see that generally, regardless of characteristics, patients benefited from the addition of TEVIMBRA. Specifically, regardless of region, whether it was Asia or the Western world, those patients seemed to benefit based on performance status, ECOG 0 and 1. And then specifically looking at peritoneal metastases, for patients with CPS score of 1 or greater, it appears that these patients did benefit from the addition of TEVIMBRA. So largely a benefit across patient characteristics here. So this is the first time actually that the peritoneal metastases for patients with a PD-L1 score of 1 or greater has been reported in this way, and where we see this benefit for this poor prognostic population. And I think this is an important characteristic to keep in mind. In addition, I think it's pretty clear that we're seeing benefit across all of these subgroups. Going on to the secondary endpoints, progression-free survival and response rate, as well as duration of disease control, we see an improved response rate, as well as an improved disease control rate and a progression-free survival of 6.9 versus 5.9 months. Again, a similar hazard ratio of 0.79.
Great, thank you. And Dr. Mahipal, if you could take us through the safety data now, that would be good.
Yeah, so just talking about, again, adverse reactions. So we do see higher incidence of immune-mediated adverse reaction with addition of TEVIMBRA to chemotherapy. I think in particular, if we want to just highlight a couple of things, the pyrexia was a little bit higher from 14 to 20% all grades. And I think rash or pruritus was higher, definitely, 7 versus 16%. Similarly, pruritus in 10% of the cases. Most of them are obviously grade 1 and 2. Then hypothyroidism, as mentioned before, I mean, again, this is an immune-mediated adverse reaction, very common, as we see in 13% of the patients. But again, grade 3 and 4 is very rare, and this can be easily managed with, a thyroid replacement therapy. I think some of the important point is what is the discontinuation rate, right? We talk about side effects, but that actually tells us like what the patients are discontinuing because of the side effects. And the permanent discontinuation rate as a whole group was about 16% of the patients, but about only 4.2% of the patients who were receiving both TEVIMBRA plus chemotherapy discontinued all treatment. So just give you a kind of a perspective, right? So because of the immune-mediated adverse reaction, the discontinuation rate is about 4.2%. And the most common IMAEs or immune-mediated AEs that led to discontinuation included pneumonitis, colitis, hepatitis, and nephritis. But again, just to keep this in mind, as we have mentioned before, immunotherapy can affect any organ of the body, and some of these can be serious and even fatal in some instances. But
what stands out to you both about this safety profile?
I think, again, just looking at this is very consistent with the class side effects. And again, we did not see any new safety signals. I don't know what your thoughts are, Dr. Iqbal.
I think this is a class effect. There's nothing new here that we were surprised by.
Okay, great, thank you. Well, now let's revisit the case. How would you manage Anne's treatment at this point?
So, I mean, again, we discussed this patient, right? So this is a patient with adenocarcinoma, GE junction adenocarcinoma, who is PD-L1 positive and other biomarker like HER2 claudin negative. We just discussed the efficacy data for the rational trial, which clearly shows that addition of TEVIMBRA to chemotherapy improves survivals, and as well as secondary endpoints like response rate and progression-free survival. So for this patient in particular, so this patient is PD-L1 positive, will be a good candidate for addition of immunotherapy to chemotherapy. So like in this case, will be a good candidate for TEVIMBRA. And typically we use, as Dr. Iqbal mentioned, we also use FOLFOX as our traditional chemotherapy, typically as long as patient is eligible.
And how does the presence of peritoneal metastases affect your decision?
You want to, yeah, take this one.
I think the peritoneal metastases data with TEVIMBRA is intriguing. So we know that these patients have a very poor prognosis. Generally, there's clear data that they have worse outcome than patients who don't have peritoneal metastases. So the fact that we're seeing activity in this population as well is reassuring.
Okay. Very good. All right, what safety tolerability issues would you be monitoring for?
So a lot of patients with this kind of regimen, which includes chemotherapy plus immunotherapy, I mean, many of the side effects will be from chemotherapy. As we mentioned, there are definitely immune-mediated AEs as well. So, I mean, we have like inbuilt in our ordering system some of these safeguards, so to speak. So look for like, abnormalities in the endocrine function, like thyroid hormones, check cortisol levels. Obviously, for chemotherapy, there's a whole host of things that you have to monitor, including blood count, LFTs, kidneys function, and so on. But also just give patient recommendation, right? Like we talk about toxicity, what to monitor for, and as soon as they have some of the symptoms like shortness of breath, diarrhea, nausea, vomiting, blood in stool, something that we're concerned about, call us right away for monitoring purposes.
All right. And if you could take us through the last set of ISI, please.
Sure. So again, I mean, this is nothing new. It's kind of, again, similar things that we saw in the first trial, that we see something similar. Addition of TEVIMBRA to chemotherapy does add to some of the side effects, especially immune-mediated AEs. It can cause immune-mediated nephritis. Again, dermatologic rashes, pruritus is very common. It can lead to severe cases, which is pretty rare, but can happen, like Stevens-Johnson syndrome, TEN syndrome, toxic epidermal necrolysis, which can be even fatal in some cases. But again, overall, if you look at, there's about 15% of the patient has some sort of a dermatological side effects, and most of them were mild, with rash and pruritus being the biggest thing. Typically, again, for these AEs, what you do is you hold the drug, depending on the severity of the drug, and give steroids to come down. Just for the rash or pruritus, grade 1, you don't have to hold the drug. You can manage with topical drugs, like topical steroids, emollients, and then continue with the therapy. But obviously, for more severe, you would require that. Similarly, some of the other, including from all sort of symptoms from like cardiac, nervous system, ocular, GI, endocrine system. But again, the common things being common, endocrine and dermatologic are more common side effects, but to be aware of any of the side effects that can affect any organ of the body. Let's talk about the infusion-related reaction. Did happens about 5% of the patients. Most of them were grade 1 and 2. Grade 3 were only in 0.2%, so very rare. But just to be aware, if that infusion reaction happens, typically we interrupt the treatment, and then you can give some pre-medications to help, like antihistaminics, and then you can restart. Again, obviously, if someone has a grade 4 or grade 3, you might have to stop the infusion and permanently discontinue and treat it. I think a couple of other things, again, for like stem cell transplant patients, just to be clear, any transplant patient, when you're giving immunotherapy, there is a risk of graft rejection, so very, very clear. And we don't have data on effect on the fetus, so we should not give it to the pregnant patients. So I think, again, this is kind of like we kind of summarize, again, the adverse reactions do happen. Immune-mediated AEs, that is something we have to be very, very vigilant about for patients who are receiving TEVIMBRA plus chemotherapy. And something similar, when we talk about the discontinuation rate for IMAEs, about 5%. And these were, again, consistent in the both trials.
Okay.
Sorry.
And if you would continue with the dosing and administration discussion next, please.
Sure. So talking about the dosing for TEVIMBRA, so it's an IV drug. The first infusion is about 60 minutes, and there's a patient tolerated 30 minutes, at least for the couple of doses I'll talk about. So actually, it just got FDA approval for the new dosing structure. So you can give TEVIMBRA or immunotherapy either every 2 weeks or every 3 weeks. So typically that depends on what kind of like chemo backbone you're using, a 2-weekly regimen or 3-weekly. In the United States, typically we use every 2 weeks. So with the 2-weekly regimen, you use 150 milligram. For the 3-weekly regimen, you use 200 milligram. In addition, they also have a dose for Q4 weekly, so every 4 weeks, which is 300 milligram, so just kind of like almost double for the 2 weeks. And for that, it does require a little bit longer infusion, like 90 minutes, but that is only given in every 4 weeks. So now we have like a lot of flexibility, so we can use it every 2 weeks, every 3 weeks, or every 4 weeks. Dosing is a little bit different, but I think it should. Basically, what our hope is that it will coincide with the chemotherapy, so patients have minimal visits and not have to additional visit for receiving TEVIMBRA. So now we'll talk about my B1 support system that they have. So they have a great patient assistance program. So most of these patients, again, it's an IV drug, should be able to receive this drug. It's a FDA-approved NCCN drug, so from the insurance approval perspective. But if there's any difficulty in terms of high copays or something, so B1 has a program for these patients, for a patient support program, and hopefully most of these patients can have treatment with minimal copays. In addition, patients can actually log in. They can call or they can log into the website, and they can be connected to the nurse advocates for practices, patients, and caregivers. There is a patient and caregiver follow-up support system as well. If they needed almost like a nurse navigator who can help them, there's a counseling support group and transfer. So it's a great program for patients, so patient kind of assistance program, and it just goes beyond just insurance thing.
All right, and Dr. Iqbal, if you could take us through the summary slide, please.
Sure. Clearly, we now have TEVIMBRA as a PD-1 inhibitor that, in combination with chemotherapy, has demonstrated activity in esophageal squamous cell carcinoma, as well as adenocarcinoma of the stomach and the GE junction in PD-L1 patients, in PD-L1 positive patients of 1% or greater. TEVIMBRA has a unique mechanism of action, which in preclinical studies have demonstrated a robust T-cell activation. It's in esophageal squamous cell carcinoma, we have data that the overall survival is 16.8 months, which is the longest that's been reported, with a combination with chemotherapy with variable backbone chemotherapy regimens. In gastric cancer or gastroesophageal cancer, we also have an improvement in overall survival at 15 versus 12.8 months. And there were really no new safety signals with TEVIMBRA. So the immune-related toxicities that we're used to seeing with PD-1 inhibitions is similar. Toxicity was noted and demonstrated to be manageable across a broad population. In terms of evaluation of PD-L1, you can, despite the fact that the TAP evaluation was used, this is a test that's reasonable. It's been shown to correlate with CPS, which we're more used to here in the US, but any really FDA-approved or institutional testing that you use to evaluate your PD-L1 status for your patients is appropriate. So tislelizumab or TEVIMBRA now offers patients a new treatment option for esophageal squamous and for adenocarcinoma of the GE junction and stomach.
Thank you very much. And of course, another warm thank you to both members of our expert panel, Dr. Iqbal and Dr. Mahipal. And now it's your turn. You have the floor. As a reminder, you can submit questions by sending a text to 912-378-1244 or by sending an email to ask@inceptioncompany.com. And please provide your name and email address along with your question, and we'll follow up with you directly if we run out of Q&A time. You can also use the chat feature on the webcast page. So let's take our first question. And this is directed to both of you. What makes you believe that TEVIMBRA is worth trying in a patient with upper GI cancer? Why is it important to have it as an additional option?
All right, so I'll take, I mean, as we mentioned before, right? So, I mean, this is a disease where we are really seeing very poor outcomes, right? The median survival has been between 12 to 18 months, and before this, TEVIMBRA data is like 14 months or less. So I think we really need better options for these patients, or different options. TEVIMBRA provides one more option for these patients. We are looking at unprecedented survival improvement as we talk about, but again, there's no head-to-head trial, but this provides an option for the patients. And secondly, I think we talk about in at least gastric cancer that there is really good data with peritoneal metastasis, which did not exist before. So we need these kind of studies to continue to confirm that there is benefit of addition of immunotherapy to chemotherapy, and we have now a new option for these patients that we can use as well.
All right. We have another question coming in, and this is for Dr. Iqbal. Are the NCCN recommendations different from other PD-1s in GC?
So they're not. To align the biomarker recommendations for PD-1 inhibitors, ODAC actually met late last year to create consistency across the studies that were done across the PD-1 inhibitors. What was agreed upon for both esophageal squamous cell carcinoma and adenocarcinoma of the GE junction and stomach is a PD-L1 expression of 1% or greater. And so this will be a class recommendation in terms of in terms of adding immunotherapy to chemotherapy. So basically what's been demonstrated is that patients who do not express PD-L1 do not benefit from the addition of immunotherapy. And so those recommendations were tailored accordingly. Hopefully this will create less confusion about the what score of PD-L1 you need to treat what patient with which drug, because there should be consistency now across the immunotherapy agents that are available for esophagogastric cancers.
All right, thank you. We have another question coming in. This is for you, Dr. Mahipal. Our P&T committee requires rationale for adding new therapies to formulary. What key reasons should I highlight for adding TEVIMBRA?
Yeah, so I think, again, a few things. So yes, we know that addition of immunotherapy to chemotherapy does improve survival in these patients with gastric GE junction cancer as well as esophageal squamous cell cancer. So we know that, right? So now I think the question is for P&T committee or pharmacy committee is like, okay, there's another PD-1, why we should approve it, right? So a couple of things I would highlight. Like we just talk about that we have data for now peritoneal carcinomatosis. We didn't have that data before. So there are patients with those peritoneal metastases that we didn't have data. Secondly, we're looking at the survival that we have not seen before. We also have now data on the long-term survival as well. So I don't want to do a head-to-head trial comparison, not want to say this one drug is better than the other, but more importantly, I think it is an additional option, and it should be provided to the patient for the patient to decide.
All right, our next question coming in is for you, Dr. Iqbal. Do we know why esophageal cancer is more prevalent with Asian population?
So it's thought to be potentially multifactorial. It could be related to, it's thought to be secondary to environment, environmental exposure. It could be underlying genetics. Also, I mean, I think there's been multiple environmental studies that have listed, nitrate exposure, hot teas, this and that, associated with squamous cell carcinoma smoking, and specifically squamous cell carcinoma in Asian countries. So there's also viral exposure. So all of that's probably contributing to the increased incidence in Asia versus the rest of the world.
All right, thank you. Another question coming in, this is to either of you. If the patient has HER2 plus, but otherwise in accordance with the label, what is to be the expected response?
So we don't have data for this population. So the only randomized phase 3 trial for HER2 positive patients was KEYNOTE-811, which was with pembrolizumab. The HER2 population has not been evaluated with any other immunotherapy agent.
Okay. Anything you would like to add?
No, just I would echo her comments, right? The TEVIMBRA is not approved for HER2 positive, so it should be restricted for patients who are HER2 negative at this point. So.
Okay, great. All right, another question coming in for Dr. Mahapal. Patients now get adjuvant Opdivo. TEVIMBRA trials excluded prior IO. How do you approach this?
Yeah, that's an interesting question. Yeah, so the landscapes keep on changing, and when these trials were designed at that time, not a lot of patients were getting adjuvant Opdivo. Although now, I would argue now with the new data with the FLOT chemotherapy, I think the role of adjuvant Opdivo is right now in question at this point. But right now, so it also depends on when the patient is progressing or when the patient has recurrent disease. So if patient got Opdivo and then just developed recurrent disease right away, it's up to you if you want to use chemotherapy backbone. Obviously, we are going to add immunotherapy or not. Other things, I mean, this is all off-label, but because we don't have any data, but we also know that there is some benefit of using immunotherapy beyond progression in some other disease. So many times I would argue, even if the patient has received prior PD-1 in adjuvant setting, we're not talking about metastatic setting, we could consider adding, chemotherapy plus immunotherapy agent in this setting. So. Mm-hmm. I don't know your thoughts. Yeah, so this is not.
No, I'll just add to that. We actually don't know. We don't know about immunotherapy beyond progression. So there is a randomized clinical trial going on right now looking at assessing IO beyond IO. It's hopefully will give us some information in this area, but I think this is largely unknown right now.
Great. All right, another question coming in for either of you. Can TEVIMBRA be given alone if chemo is held due to toxicity?
Yeah, so certainly, this is kind of a more practical questions, right? Not just about the trial patients. So, yeah, so many times we try to continue some sort of chemotherapy with immunotherapy, but if you have a disease control, we all certainly have those patients who have done very well, have some toxicity, and just continue with single agent IO, and they have disease control for a long period of time. But again, in general, we try to continue some sort of chemotherapy along with immunotherapy because of the risk of progression, which could be a rapid progression in patients. So.
Okay, good. All right. Another one coming in. Again, this is for either of you. For patients with advanced disease who are HER2 and negative for peritoneal mets, what is your preferred 1L treatment PD-1 inhibitor in this space? Are preclinical studies influencing decision in regards to T-cell activation?
Yeah, this is very tough. I'll just take a first stab and then I think both of us. So I think it depends on, it will depend on the institutional practices, preference of the patient, preferences of the providers, what they're used to, right? So now we have multiple agents approved in this setting where addition of chemotherapy plus immunotherapy, I know that will be the main backbone, right? You have a chemotherapy plus immunotherapy, so that's what you're going to use. The choice of PD-1 inhibitor would be up to the institutional practice. There's no head-to-head trial, so hard to say that one drug is better than other. The preclinical data for TEVIMBRA is definitely very intriguing, but whether it leads to better clinical efficacy, we don't know that till we do head-to-head trials. I don't know what your thoughts are.
No, I would agree with that. I mean, I think it's clear that this is another immunotherapy drug that has activity. In terms of which particular agent to use, I think if you want to be a purist, you could look at the underlying chemotherapy regimen that you're using in combination. But I think we generally accept that, particularly in gastric and GEJ adenocarcinoma, we're seeing similar activity across the IOs.
All right, one more question to the panel. What would you suggest as a pain agent if a patient wants something for pain that is localized at the esophagus?
Now, when you say pain agent, I mean, obviously there are a lot of pain medication, but I mean, if the patient has been on systemic therapy, the metastatic disease is controlled. I mean, we can certainly do some other localized therapy like radiation therapy to help control the symptoms. You certainly do that, and depending on your institution, I mean, you can do 5 days or even less days of radiation so that you don't have to interrupt chemotherapy.
All right, very good. Well, that was our last question. Thank you all for submitting such insightful and thought-provoking questions. And a big thank you to our panelists, Dr. Iqbal and Dr. Mahipal. We hope that you have thoroughly enjoyed this evening's broadcast. On behalf of B1 Medicine, I'm Patricia Stark. Have a great night.